Thank you very much, Ma, in person of Mrs. Ido. Thank you very much. Thank you for the opportunity. I would also recognize the presence of Dr. Raphael once again. We're actually happy that you joined us. And my colleague, Dr. Gabi, I'm happy that you're here. Thank you for joining us. Mr. Abdesi, thank you for joining. And so many wonderful people already in the room today. Dr. Awede Kainde, thank you for coming. We have 50 participants already. So thank you all for coming. This is medical coding webinar. My name is Mercy Idowu. I'm an information manager, a medical coding specialist. I run Mesure ICT Healthcare Consults, an organization that deals with installation, design, and development of healthcare software, amongst others. So it's a pleasure to have you join us today. So I will introduce the speaker for us today, a person of Dr. Folashayo. So Dr. Folashayo is here with us today. So he's going to be taking us through the session. So I hope we are all ready and set to learn from him. So Dr. Folashayo is an award-winning alumnus of School of Health Records, Hospital Ibadan. He has vast experience, vast knowledge in medical over 2 decades. So I think we are in the right position. I think he's in the right position to teach us and talk to us today. So that is why we have him as our speaker for today. So without further ado, I'm going to invite him. So he will take charge of the mic now, and then we can start the whole session. So please, I want to encourage you, please mute your mics, stop the video. We really want the speaker have access to the video. So we can start now. So Dr. Folashayo, sir, thank you for coming. We appreciate you, sir. So please unmute your mic. Dr. Folashayo.
Good afternoon, ladies and gentlemen. My name is Bamhon.
All right.
Good afternoon once again, ladies and gentlemen. I am Folashayo Ayegbayo, and we have this serious business to transact together this afternoon. And I believe every one of us that is on board will not in any way have a dull moment. I want to believe the reason you have joined this presentation or this webinar today is because of your interest in the development of the profession, health information management, and also the sub part of it, which is the clinical coding profession on its own. So once again, I want to welcome you, and I believe that we'll all enjoy the session together. Thank you very much once again, the moderator and his co-moderator. Thank you for your support. Thank you for everything you have done. And basically, this webinar is being structured or is partitioned into 2 parts. We are going to have a first part, which is going to address the state of clinical coding in Nigeria, in the Nigerian healthcare system. And if you have seen the theme of this webinar, we said repositioning clinical coding in Nigeria. So we want to look at the present state and what is it that we can do that can help us to reposition or take us to the level, to the stage where we are expected to be as practitioners of this particular profession in this country. So I would like you to please join me in this journey, and by this very special grace of God is going to be a wonderful moment for all of us. I believe you can see my screen now, and on the screen, we are talking about repositioning clinical coding in Nigeria. And the second session will be looking at key indicators or key points in COVID-19 coding, talking about COVID-19 guidelines as it has been released by the World Health Organization. So let us start, and let us first and foremost. So we are going to have a kind of a break in between the two. We will first look at the state of clinical coding in Nigeria and what we need to do to reposition. And we'll have a moment of about 5 minutes break before we begin to look at the second session, talking about COVID-19 coding guidelines. So join me in this journey as we move on. These are the objectives that we are going to look at together. I believe we'll be able to do justice to all of this in this first session of this webinar. And as you can see it on your screen, we want to assess the present situation, the state of clinical coding practices in Nigeria. And we'll also highlight the challenges being faced by clinical coders in Nigeria. I'm going to talk about that, maybe so many unscripted things that will be said about that. And the third part of the objective is to identify the impact of technology and artificial intelligence on clinical coding, of course, globally, and the impact which, of course, we must replicate in our country. And lastly, there we want to say what are the solutions we can provide to those challenges that have been identified. So they say that necessity, many of us will have had that saying at one time or the other. It says necessity is the mother of invention. And I asked somebody, a friend based in the US, I noticed that she changed her designation or her official title to, instead of CEO, she became CIO or CRO. CRO. So I asked, what does that mean? She said, CRO means Chief Reinvention Officer. Now, this is what I want to bring out from this point. The state the whole world is in now is a precarious state. And it will only take those who are ready to reinvent themselves, to reinvent their processes, to reinvent their organization, in fact, to reinvent their profession. It will take them to actually survive. So she said that change, which of course is the most constant variable in nature, is the mother of reinvention. You can also say disruption. COVID-19, as it were, it has disrupted quite a lot of processes all over the world today. Businesses are shutting down. Healthcare is being challenged. Nations are entering into debt, recession here, recession there. So better still if you say disruptive change. is the mother of reinvention. And so, those of us on this side of the divide, in this part of the world, we cannot be left behind. And that is why we need to rise up to the occasion. We need to do what has not been done before, or we need to look at what has been done before and begin to redo it in a different way. There is the saying that you cannot continue to do something in the same way all over and over again, and you'll be expecting a different result. So, as we can see, the traditional processes that we are used to in our hospital settings, in our HRM departments, the way we do our codings, clinical coding, our profession, even in businesses and organizations, can no longer sustain us in the face of the present challenges that we are facing. So this is a time of so many uncertainties, and it will be very good for us to look inward. And that is why this webinar is coming. If you permit me, I will say it is very timely. So at such a crucial time like this, we need to definitely do something. We need to ask ourselves some pertinent questions. Follow me very closely. I believe everybody is attentive and you are hearing me. The
Yes,
first
sir.
question is, all right, thank you very much. So the first question we need to ask ourselves as a group of people that belong to a body of knowledge is, do we have the right resources to support the new normal, the new innovations and development, the new challenges that these times of uncertainties is throwing at us? Do we have the right resources? Well, your guess is as good as mine. Your answer may be yes, and your answer may be no. The second question, do we have the right processes to innovate? That's another huge question. I'm not expecting us to answer it yet, but definitely these are questions that should guide our actions, our thoughts, the things we should do and the things we should no longer do. The third question is, do we have the right values to help us reinvent? Value is something that is intrinsic. Value is what makes you, we should not mistake value to ethical conduct. No. Value is much more deeper than ethical conduct. Ethics is more concerned with moral values, but when we talk about values, it is much more deeper. We need to look at a bit of that. Another question we need to ask ourselves is, what team and structure will best support our innovation effort? Yes, we have made up our mind. We don't want to remain where we have been. We want to take a step further. Then what are the things we need to do? What are the structures we need to put in place? The structures that will support the innovation effort. If you agree with me, there are so many structures that are missing, both in the HRM profession and also in clinical coding. Generally, in the country, Nigeria, there are a lot of challenges that we face. And so we'll move forward. Let's look at what clinical coding is like in Nigeria today. I know I'm talking to well-experienced, majority of us are on the field. We may even know some of these things. We see most of these things day by day, even better than some of us in the academic institutions and IVITA. We only come in contact with most of these cases when we are doing researches and we are trying to gather data and we do some other form of, but you can't take anything away from researchers, because that is what we do. We gather data to back up, and everything that we say or that will be said in this webinar today, let us consider them as statements of facts. And if there is anything that we need to do to change the status quo, we should begin to think about them so that the journey will be smooth for all of us. We all know that clinical coders, their role is pivotal to the healthcare services. Yes, we know that. When we were in school, we were taught that, oh, they said that the Department of Health Records Management in a hospital is the pivot on which all other sections of the hospital revolve. Yes, that is the truth. That is the truth. But the problem is the authorities will not want you to believe that. Yes, it is in your books, but nobody wants to acknowledge that fact. So the role of the clinical coders is pivotal to the healthcare services. The clinical coders are the ones who use health records to translate clinical terms into a sequence of codes. We know that, which describe the diagnoses and procedures that have been documented into the patient's record. But there is a long question I want to ask here. Can it be said that the health authorities, I think I've paraphrased it earlier, can it be said that the health authorities in Nigeria recognized and taking advantage of the benefits of good quality coded clinical data and the important contribution it can make to the safer care of patients and effective management of hospitals? I do not expect you to answer now, but they say actions speak louder than words. The way health authorities see clinical coding, in fact, it is not something that is known to majority of like HRM department or health record or medical record, as they choose to call it, is there. And that is where you get the patient record. And basically, they don't want to know any other thing more than that. But those who are in this back room of clinical coding should identify. Let me quickly say this. If the use of a thing, a particular item is not known, they say that an abuse is imminent. I will say that again. If the use of a particular thing is not known, an abuse of that thing is unavoidable. Somebody will abuse it, will misuse it. And so when the health authorities do not appreciate the importance, the benefits of good quality coded clinical data, definitely it will not be appreciated. So before we move on, there is, I believe, 99% of us attending this webinar, we are HIM professionals, health information management professionals. And many of us, we've tried to put our head, go down into the trenches, and we give ourselves the title. I use the word we give ourselves the title clinical coders. But in the real sense and in the true sense of it, we don't have any such title in Nigeria. The scheme of service, the civil service scheme of whatever they call it, just recognize medical record professionals, medical record technicians, yeah, I think officers now. So, which of course has a limiting impact on what we can do as clinical coders. So that is one major limitation. I don't want to dwell too much on that, but definitely there are a lot of other things we can say. So let that just be a point that we need to take note of. As of today, no professional is being addressed as a clinical coder. In fact, even though clinical coding is a profession on its own, but in Nigeria, the situation and the true picture is we do not have certified clinical coders. That is an incontrovertible fact, and we must take note of that. And something has to be done about it. Also, another major thing we need to look at, and it should be a source of concern to all of us, is that as far as I know, in the past 30 years, it may even be more than that, the methods used for collecting data, clinical coding, has not changed. It has remained the same. It has remained the same. It is only in the textbooks that the majority of us knew that there are electronic coding, there are mechanical coding, manual coding, and at what point have we moved beyond manual? Yes, many other countries of the world, they are still grappling and trying to see how they can work around it, put in electronic system. Howbeit also, the electronic system also has its own limitation and disadvantages, which of course, time will fail us to look at all the details today. So the fact is the coding process is a manual task that requires a specialist trained member of staff, the clinical coder, to transact episode of care in hospital administration system. So as we know, in Nigeria also, as of today, there is no nationally mandated training or certification for clinical coders. I believe everybody will agree with me. I'm not talking about having a board that licenses HRM professionals, but when we talk about having a group of people referred to as clinical coders, there is no nationally mandated training. There is no certification program for clinical coders. So, which means if I use that title, maybe I just dash myself, but we must go beyond that. We have come to that vantage position in our professional practices and experience that this is the time for us to actually address all of this. Don't forget the point I made earlier. You cannot use a solution that has not been working for many years to solve a new problem. A method that has been failing cannot solve a new problem. And these are the things we need to pay attention to. Now, as we all know, we know that majority of our patients' records are still being maintained as in paper formats. And these are some of the challenges that we face when we are making use of paper-based patient record. You can see that it can often be in poor condition and not necessarily in any order. And if you have been a coder, you have been practicing as in working in the coding office for some time, this is one thing that gives headache when you are holding a record and you must work with it. And the state of that record is very poor, disjointed, all the papers scattered, all the things you need you cannot find. So it's one major problem. Also, coders often resort to using discharge summaries, but the quality of such sources can often be inconsistent and incomplete. In fact, many patient records do not even have discharge summaries. The clinicians who use them, who should write them, will not do so. Well, a few years back, some will not even write what their diagnosis was. And I believe all these things are changing and it must continue to change. And also, the paper record can outrightly go missing. Can outrightly go missing. And that is one problem. You, as an HR professional, missing case file shouldn't be new to us because it is paper-based, it is portable, someone can carry it, it may be misplaced. And if you look at your notebooks, you see about 12 reasons why a case file may be misplaced. And maybe through misfiling, I don't want to go into all of that. Also, another challenge being thrown at us because we are still so much using paper-based record format is that it could be in use by someone else at the point that the coder needs to use them. Yes, a discharge case file, which of course is supposed to be with the coder, is still being held somewhere else. Maybe a physician who is interested in some research effort is delaying them, and all of these things affect the quality of coding. And I think the last one that is that it can sometimes be difficult to read the handwriting. Of course, handwriting, illegible handwriting of physicians is, of course, a big headache to coders. Now, the fact is, in Nigeria today, we have some, even though there are few, but there are some health institutions that have tried their hands on electronic patient record systems. And I said earlier that there are challenges being faced too. The first one is if you must make use of that as a coder, the patient record is electronic. The first major problem we have, because don't forget, the electronic systems of patient records that we have in Nigeria today, they lack standard. There is no standardization yet. And that, of course, makes it difficult. There is no structure. And so you may have different vendors, you have different designers. There hasn't been any standard being, when I say standard, I mean the technological standard, what kind of compatible software to be used, what can work on what hardware. These are some technological issues that emanate. So this will lead to lack of structure of how notes are recorded, leading to coders needing to draw many different systems to ensure they have the accurate information. So you can say that if the electronic patient record systems lack standard, the same problem being faced with paper records is still the same one that will be faced, because there are no structured arrangements of the cases or the clinicians. Secondly, coding standards dictate that coders can only code from the current patient spell. That is the standard practice. That is the last episode of care. The patient has just been discharged, and you must extract the diagnosis from the last episode of care. But you say that in our electronic patient records, the system is so designed that you have accumulative entries, and which avoids clinicians having to update information that may not have changed, such as comorbidity. So these are some of the things. I just want to believe I'm not moving too fast. I need the feedback, moderator. Moderator, can I move on?
Yes, you can move on.
All right,
Yes,
thank you. So, another major concern is variation in the implementation of coding standards and record keeping systems. One fact that cannot be controverted as of today is that there is no standardized or standard clinical coding guidelines. Let me put it national clinical coding guidelines or clinical coding standard in Nigeria as of today. There is no office either at the federal ministry and in virtually all the states of the federation that is set aside, no office that is set aside, no group that is set aside to say your duty is to always revise and review and to come up with standardized clinical coding guidelines, either for a state or for the nation. We still don't have that. But when you go to other countries, in the US, they have clinical coding guidelines, which they review annually. Apart from the fact that the WHO releases, updates, these nations go to the UK, they have the NHS has a body that reviews and come up with their coding guidelines yearly. In fact, in this COVID-19 era, we've had a lot of amendments made to their guidelines because many things are changing. In the last 6 months, a lot has changed. And so guidelines upon guidelines, guidelines upon guidelines. But you don't see that happening in Nigeria. And that is because we don't have it. We don't have it. The only thing we always know is WHO has released a new version of the ICD or WHO Family of International Classification met last year, and these are the new updates. In fact, many of us don't even get abreast of the new updates. And so these are the things affecting the quality of work and the quality of data that we produce that are produced by our clinical coders and by extension in our health information management offices nationwide. And so we need to look at that. And also with little regulation and no mandate or guidance on how records should look and what should be recorded in them, it means there is a lack of clarity when it comes to best practice. Let me quickly say a few things on that. You discover that how a particular physician chooses to write in the patient record. Is there any regulation to it? Is it being checked? Yes, we were taught back in the days that the patient record is actually used for accreditation, and it is also needed when it is reviewed to decide whether a particular physician or a healthcare provider will deserve a renewal of his or her license. But you and I know that that is only in the books. It's only in the books. We don't see it happening. And so you see clinicians entering, writing. I was told in a particular general hospital somewhere in Lagos a few years back that some GP, general practitioners, will just write sin. And that's all they put. They put the patient name and they put sin. So there are no regulations or guidance on how records should look or how entries should be made into the patient record. So these are things that are seriously affecting us. All right. And another part is coding standard and episodic versus longitudinal working. Let me quickly say a few things there. We know that coding activity is episodic. A patient comes to the hospital. At the end of that episode of care, the patient is discharged. And that case file will be coded based on the most recent episode. But when we introduce the electronic system, don't forget, most of our electronic health record systems, they are being designed with a longitudinal principle. That is just a longitudinal, that is the same record, everything that has been entered about the patient. The thing is that a patient may have a label asthmatic, and that may not, that label may be one major thing that you keep saying. That is, of course, that also boils down to the fact that entries are not being monitored. But we should also know that while we are setting up standard for coding, we should, or many of us, we find ourselves in positions where they will call you when your organization or your state government is designing an electronic system. These are some of the things we need to bring up for discussion. That are we taking cognizance of the fact that clinical coding will be done based on the information that is entered into the electronic system. Longitudinal design is okay, is good for the electronic health records. That is actually the principle behind electronic health records. That is, a patient will have a single record from birth, from the time of birth to the time of death. But don't let us forget that the system needs to be designed in such a way that different episodes of care will be partitioned. So these are the things that we need to know. It's pity that most of the systems that I have seen in use presently that you hear of or try to look, they don't take this into consideration. And of course, this end up affecting the standard of coding. And the coders, of course, they end up not doing what they should do appropriately. Of course, you can't blame them, but you can blame those who were called into the design stage of the system, but they couldn't make the impact expected. Now, let's look at the next point. We will soon round up this part. Our time is gone. Cultural challenges around the importance of coding. When we say cultural, that is, we are talking about our beliefs, what the views that we've been having and holding. Now, the current view is that coding should not be considered a back office function. If I may ask us, definitely I cannot hear you, but I know that in our various hospitals, if you work in a teaching hospital or work in a general hospital, hardly will your MD even knows that you have an office called clinical coding office. All they care about is, oh, just go and bring data. I don't want to sound too academic, but one thing is that the present day coding, clinical coding, it is majorly used to measure performance, outcomes, and also for benchmarking. Of course, reimbursement is there to measure performance and outcomes of care given to the patient, and also for reimbursement purposes. So these are the things that we need to have at the back of our mind. So when the managers, or let me say the management, are not even aware that this thing exists. So it is high time for us to come out of that backroom position where clinical coding has been put. So the view as of today all over the world, in countries where clinical coding has been given its rightful place, is that it is no longer a back office function. It is no longer the data inputting role it once was. So there is need, there needs to be a greater focus on training and investment in people who have the skills to take the role forward. So we cannot overemphasize this point. There is need for us to come out, to join hands together. Yes, HIM is a profession, is a modern profession. Let me quickly say something here. I mentioned something, and I know that some of us may want to bring up questions in that area, that clinical coding is a profession, just like HIM is a profession. Let me quickly cite an example. I don't intend to cut some controversies here. Please pardon me. The point is, when somebody, an MBBS student, is in school, he reads microbiology, biochemistry, all those basic medical sciences, anatomy. He studies everything. He even, in their part 4 or 5, they do pharmacology, almost for a whole 18 months, pharmacology. But does that make him to be a pharmacist? No. Likewise, an HIM professional we do coding. While in school, we were taught is the core course that we do, just like pharmacology is a core course for a medical student, but that doesn't make him or her a pharmacist. Likewise, the amount of coding that we do in HIM does not translate to the fact that you're automatically a clinical coder. So when you want to specialize as a coder, yes, you have finished your HIM, then you specialize, you acquire certification, you build up your skills, because clinical coding is not something that is just about, yes, I know how it is done. It is experiential, and it is a skillful practice. A skillful practice. So maybe in the future, we may have to talk more about that. And I pray God will give us the time and the opportunity to do so. So using available technology, the role can evolve to become a key part of the drive for improving patient care. And that is one point that we must sell to everybody all around us. And we even want a situation whereby many of us who can have access to these slides that are here can cascade all of this, during our, what is it called, continuing medical education in our various institutions. Let's cascade it down. Let's invite other professionals, and definitely I believe something new will happen. All right, quickly, as I'm drawing closer to the end, another area of interest is that helping clinicians understand the importance of coding. Let me quickly say something before I leave this. A few years back or so, I was doing preparing some papers, and something came up in our discussion in class. Of course, it's a topic we were treating, and we were talking about physician queries, and we designed a format. I sent the students to respective general hospitals in Lagos State. That was about 3 years ago now. And the feedback we have from the various general hospitals was not encouraging. What is a physician query? We just ask them to go identify a number of deficiencies in the patient records, especially entries that are made by the physician. And so look at how these deficiencies could be addressed. Definitely don't let us have the mind that physicians are 100% perfect. They make mistakes when they write. Some of our colleagues in these general hospitals told the student that, you won't sack me. How can I go and be, I'm sorry, I spoke Yoruba there. Do you want them to sack me? How can I go and be querying or questioning doctors that they didn't do their job? Well, you are not querying them. You are only trying to improve the quality of work done. There is a certification today, which they call clinical documentation improvements. HIM professionals can acquire that certification. You have nurses who acquire that certification. In fact, you have doctors who acquire that certification. The goal of that is to ensure that the quality of documentation in the patient record is improved upon. Because when a poor quality record is sent down to you, it affects your work. And so the onus is on you to identify these deficiencies using an approved physician query, and get it back to the physician who has who attended to the patient to take due diligence. Oh, can you shed more light on this, so that your coding effort will be easy for you, so that we find it easy, so that you don't have to guess on what code to assign. So these are some of the things we need to understand. Likewise, communication, of course, is still about the same thing. I think I'm trying to pull it all together. Communications between clinicians and clinical coders. It's not something that we need to do this. We need to work hand in hand. We need to work hand in hand with physicians to make them know. But if you don't come out of your shell, if you do not make them know that what you are doing is actually, there are some things in my head that I want to say, but definitely I wouldn't want to say because some people might think it is controversial. And let me just thoughts about it. An HRM professional is like an examiner, or don't let me say HRM professional. A clinical coder is an examiner. You are examining the entries that have been made by a physician about a patient who came for, consultation, who was admitted. So you are looking at it, more or less you are reviewing it. So which means your level of knowledge clinically is higher, must be very high for you to be able to do. It is not, clinical coding is not just about identifying diagnosis or the procedure. No, it goes beyond that. So we need to, up our game. We need to go to the level where we should be. We need to operate at the level where we should be operating, because the things happening around the world today, there are certain things I will not want to say in this gathering because this is a large gathering. I don't know who is listening, but the thing, and you don't open up everything. So, but in some other gatherings, when we have, people of like minds, we'll be able to look at it and how to strategize and how to move higher and leave all of these things behind us. So, getting close to the end now, correct use of language and terms, all right? Without guidance, talking about, all of these things we are talking about is still, it boils down to lack of guidelines, coding guidelines. Nobody designs guidelines for us in this country. We don't have it. All that you have, it is your ICD-10. No guidelines. Nobody tells you, oh, this is national guidelines. Yes, the ICD-10 is an international thing. The WHO you only report making use of the first three characters, the three character categories. What of the other ones? How will they impact on the quality of data? How will they affect positively the healthcare system? We don't bother about that. So there are so much more we need to do. So without guidance on what should be recorded in notes by the clinicians and how it should be recorded, there will always be a risk of misinterpretation of the information by the coder. So, and that will lead to wrong coding. And we code wrongly and we escape because the use to which we put our coded data is not even we are not making use of our coded data for what it should actually be used for. Because if you use it for benchmarking, if you use it for measuring outcomes, if you use it for performance evaluation, definitely, not to talk of reimbursement. So these are four major things clinical coding, coded data are being used for that we don't even, consider. Majority of them in this country. Reimbursement, of course, zero. Many of our HMOs who are charging people, their methodology is defective. And all these things it boils down to lack of properly coded data. They don't even pay attention to coded data. Their methodology, their billing methodology is defective. And I can say that to their face. So to avoid this, it is vital that clinical terms are used and where available. So let's quickly talk about the impact of technology and artificial intelligence on clinical coding. Just one slide, and then we'll go to our solution and recommendation. So technology is rapidly evolving, and it's tech vision of the future. So in this COVID-19 era, everything is going to be overtaken by technology. Artificial intelligence is going to be the in thing. And so all of us must be on board. We must be ready to begin to reinvent. That's why I started with reinvention analysis, analogy initially. we need to start to reinvent. We need to start to reinvent because the way we used to do it can no longer sustain the process. Our value must change. We must acquire more resources. We must be able to do things differently. So while some coders fear that the introduction, I think many of us have this fear, we fear that the introduction of artificial intelligence will put our jobs under threat. So the intention is actually to make our jobs easier and quicker. That's just it, and to make it to be more accurate, our deliveries. So these are the things we need to know. There is no need to fear when they are using robots to code, when electronic health record is out, when automatic coding is out, it will lead to loss of jobs. No, because technology is not a substitute. And that is a fact. It's not a substitute to human brain. It can only help us to do our work better. All right. What are solutions? Just two of them there, because, and then we go to recommendation. Developing a clear mandate. Developing a clear mandate for the digitization of patient records, because that is just the way. A clear mandate for digitization of patient record. That is the way. COVID-19 has opened all our deficiencies to us. And so we need to digitize. Don't forget telehealth, and of course, telemedicine is the in thing now. COVID-19 has really changed the landscape of everything. So, and digitization technology is the in thing, and so we must look in that direction. So we need to have a clear mandate, and also addressing the cultural challenges around the importance, most of which we have mentioned. So what are the recommendations? Very quickly, end the variation in job description. Okay, so we need to have clinical coders being identified as clinical coders. That is the way to go. We need to consider the future role of coders and support with training. Coding is something that changes because guidelines must be released from time to time. And so constant training, frequent training is what makes coders to be coders. We need to move toward real-time coding. Real-time coding. We need to move forward, towards that. Technology will help us to do that. Digitization will help us to do that. Better coding standards and a mandate to enforce better quality is another recommendation. And also, improve knowledge sharing and understanding from health authorities about the importance of good quality data. That's why I said we need to write to the authorities. We need to make them know that there is a key part of health data management that is being neglected. Many of the systems of healthcare system, the technology that has been designed today, many of them are not taking into consideration the place of clinical coding. And so we must throw that up. And also, lastly there, to improve communication with clinicians, a clinical coder must always be ready to have a tete-a-tete with the clinician, with the physician who made the entries and anytime you identify some deficiency, there should be some format of physician query that you enter everything and you ask for further information that will help you to do your job more accurate. Or session 1 of this presentation. Like I said, the second part is not going to be as lengthy as this. And I will want to hand over to the moderator so that they can tell us what we need to do before we. I really appreciate you for listening.
All right. Wow, that was a very wonderful session. It's mind blowing. We actually appreciate you. Thank you for the knowledge you have shared. It's wonderful. Thank you very much. So we're going to take a couple of questions now. So please, I will encourage you, please drop your questions in the chat section. So I will have access and read them out to our speaker, please. Leave your question. So I have a question now already. All right. Mr. Ruben Ogun Oduleke wants to know. He said, is that actually a question? Now, the question mentioned, the action mentioned as regards querying physicians' documentation is also to help them, again, negligence on their own part. The deficiency is liable. I think it's just contributing. So the question again is, can e-coding app stand alone in a facility or must be embedded in EMR? That's number one question. And then number two, he also, Mr. Adebisi now is asking, what is the procedure to acquire certification in data quality, as you said? So please provide answers to that, sir. Hope you got the question.
Thank you.
Yes, sir.
Thank you very much. I think the questioner talked about physician query.
Yes.
Physician query and whether e-coding can stand alone.
Yes, sir.
All right. And what was the third one? The process of certification.
Yes, in data quality.
Right. Okay. Now, I know that the questioner puts it, it is like a double-edged sword, as it helps the coder when we institute a querying process. It helps the coder to do its work well. In turn, it reduces at the physician or the documentation that the physician has, put down. That doesn't mean the doctor does not know what he or she is doing. He must have done well. He must have written, but maybe spelling error, maybe some omission when you are writing. So, which of course may change the meaning of the context. So, and that is why when a coder is going through this, the patient case file, and you identify some of these things, it is right. You cannot correct it. You cannot it's very right and very much in order. For you to send it back to the physician, ask it correct, sign, and date all of these things properly. So these are some of the things that we need to start to put into practice. Now, the question as to whether e-coding can stand alone. The answer is yes, you can have electronic coding system. And electronic coding system can also be inbuilt in the electronic health record system. But the point is, if you have an electronic coding system and you are extracting your data from a paper-based patient record system, you can see that incompatibility. So, which means the main objective of using electronic system may still not be so achieved. So it's better either you have standalone electronic coding system and you have your electronic health record system, or you have an integrated system in which everything will flow seamlessly within the electronic system that have been designed for the patient management of that particular institution. So the other process of certification, because of some considerations, I may not want to talk about that now. But the point is that as of today, process of certification in Nigeria is non-existent, and something has to be done about it. Thank you. Over to you, Mr. Moderator.
All right, thank you very much, sir. You see about another question from Mr. Olani Olaoluwa. He said, now that we don't have clinical coding as a profession and it's embedded in health information management in Nigeria, is it possible for clinical coders to form an association which can work on the clinical guidelines for the nation? I think that's a very good question, sir. And we also have another one from Mr. Abiodun.
It is.
Just hold on, sir. For Mr. Abiodun Ashiwaju, he said, sir, what is the relevance of clinical coder when coding can simply be done electronically? That's a very beautiful one, sir. All right, over to you, sir.
All right. Okay. The first one, if it is practicable to have clinical coders association when it has not so been existing as a profession in Nigeria.
Yes, sir.
For many of us who know the history of the development of health information management in Nigeria, the association of practitioners actually started the training. I want to believe you agree with me, Mr. Moderator.
Yes, sir.
From the history of the development of health records. So, which means it is a guaranteed right in the Constitution of the Federal Republic, freedom of association. So while you are developing, look at it, many of our pioneers, they went to study abroad. D.O. Akanji, E.T. Jagun, all those people that we hear of in history, they all went to study abroad. And so when they came back, they formed an association. And so with that association, they started the training of others. I believe that to associate is not actually a problem. It's not actually a problem because there are a few things. Let me quickly say a few things. What makes a profession to be a profession? And if you have a writing material, I would like you to write it down. I have it here. The characteristics of a profession. Number one characteristic of a profession is that there must be a professional association, which means a body of professionals coming together, sharing common interest. That is number one characteristic of a profession. Number two, they must come up with a code of ethics that is going to guide them, a code of ethics. Number three, there should be a unique body of knowledge. That is what they are studying or what they studied or what they intend to study. A kind of a curriculum, a kind of a domain, something, knowledge domain that the profession is all about. There should be a system of training. All right? These are the things that make a profession to be a profession. Also, there should be professional cohesion, that is coming together, doing conferences, doing researches. And lastly, number 6 is there should be professional literatures. You agree with me that we have writers. Even in Nigeria, we have people who have authored books on clinical coding. And these books are not only being read in Nigeria, they are even available internationally, being distributed on a global network. So we have all it takes to do what we want to do, except we are not ready to do it. Thank you.
All right, thank you very much. That's short and brief. Before we go forward, I would also like to encourage us, please make sure you enter your details. It's very important that you register your details. And I just want to take this minute to appreciate the presence of the Southwest Coordinator of Health Records Officers Registration Board of Nigeria, the person of Mrs. John Champion Afolayan. Thank you for joining, man. We actually appreciate your presence, man. Thank you for coming, for joining us. And so we will have to go to the
Okay, thank you so very much. I appreciate.
All right, man. Thank you, man. Thank you, man. So go to the second section of this webinar.
Right, sir.
So we'll do the overall of all the questions. We take all the questions together. So we'll go to the other section which talks about the COVID-19 diagnostic code in line with World Health Organization. I believe all countries of the world, they have their own guidelines. And it's a shame we don't actually have one in Nigeria, but I believe we will get that by God's grace. And in US, they have the guidelines signing that COVID-19 diagnostic code. So what we're going to be dealing with is just the guideline according to WHO. So please, let's go over to the second section. So we'll take the whole question together when you're done. Thank you very much, sir.
All right. Thank you. Thank you. Once again, ladies and gentlemen, I want to welcome us as we go to the second phase of this delivery. And I believe at the end of it, everything we are doing will all be worthwhile. So we'll be looking at COVID-19 coding guidelines. Definitely, as we know, the guidelines we're talking about, they are not what we have not had before. We are all aware that the World Health Organization has actually released new codes for COVID-19. And but how do we put them to use? I am aware that this has been given some concerns to those of us who have been coding in institutions, and there have been areas where we disagree, which code should go for which one. Yes, even before COVID-19, we used to have coronavirus in chapter 1 of the ICD-10. And so some people ask, of what use is the new code that has been released? Definitely, I want to believe that at this juncture, we all need to understand that the guidelines for COVID-19 is not, it's released for a reason. It's released for a reason, and we must be ready to make use of it and use it rightly. So I want to bring my slide back to the screen so that we can all see because this is more or less like a practical session, and we will all need to see what has been put there. So just bear with me. Let me bring up the slide. So talking about COVID-19 guidelines, we know that as of today, the WHO released codes, and these codes are put in the reserved chapter, which we call chapter 22 of the ICD-10, that has the initial alphabet U. And we know that that initial alphabet U is used for unused, how do I call it? It's an unused alphabet in the ICD-10, and they call it codes for special purposes. I believe also that ICD-10 is an health emergency. And so the code that has been released by the WHO is actually an emergency code. Yeah, despite the fact that we have a B34, B90 something, 97 existing before now in the chapter 1. So we are talking about the emergency code. How do we use it vis-a-vis the existing coronavirus codes in the chapter 1 of the ICD-10? So let's look at what we have on the screen. You have U07.1. That is COVID-19. Let me quickly say this before we move on. Since March or April, when WHO released these guidelines, there have been amendments. And I also noticed that there are nations who also have modified it to suit the system and their response to COVID-19 in their various countries. So, and that is why in Nigeria, you know that COVID-19 is a global health emergency. We cannot afford to do anything wrongly. So U07 is an emergency code for an emergency use. All right. So you can see on the screen that COVID-19 virus identified. What does that mean? It means when there is a laboratory testing that is done and it is positive, confirmed laboratory testing that the patient, this is a positive case of COVID-19. Irrespective of the severity of the clinical signs or symptoms, this is the code that will be given. Once it tests positive, either the patient is symptomatic or asymptomatic as at the point of testing. So this code is assigned. Initially, when this code was released in March, April, they used to differentiate between whether the patient was symptomatic or asymptomatic. But as of today, starting from July 1st, because this is about the most current of the guidelines, either it doesn't matter the symptoms being shown or the patient is not even showing any symptoms. Once a patient tests positive, this is the code. And you will see the exclusion notes there. It says it excludes coronavirus infection on specified site. What do we use excludes for? Students of clinical coding, it tells us that, yes, even though this particular code, B34.2, coronavirus on specified site, looks like it should be the one to be assigned, but exclude it. It should not be used because we are in the period of an emergency, health emergency, global health emergency. So that is the reason B34.2 is not being assigned to laboratory tested positive COVID-19 case. Another point in the exclusion is coronavirus as the cause of diseases classified to other chapters. That is when coronavirus is responsible for another condition, which of course is classifiable to another chapter of the ICD. So you will also exclude it. So if a patient comes, the patient is being treated for, let's say, a particular condition, the patient is asthmatic or has pneumonia, and the patient is testing positive to COVID-19 also, it means that we are not going to use B97. It will still be U07.1. So that is the guideline as of today. And also excluding severe acute, we know about SARS, unspecified, which also, of course, is classifiable in chapter 22, U04.9. All right, so that is about U07.1. We have U0.2. U0.2, COVID-19 virus not identified. Look at the notes, the explanatory note that follows. The explanatory note says that use this code when COVID-19 is diagnosed clinically or epidemiologically, but laboratory testing is inconclusive or not available. What example can we give? Okay, somebody has been, we talk about isolation period for 14 days because the person has been exposed, but during that period, testing has not been done. Even though if this person is hospitalized during that period, or this person has been discharged from the hospital, and testing, laboratory testing is still inconclusive, as at the time the patient is discharged, or there is no results available as at the time of coding, and it has not been confirmed that this patient tested positive, despite the fact that the clinical notes written by the physician, attending physician, shows that this patient was exposed to COVID-19, you will not put U07.1, you will use U07.2 because the virus has not been identified. And you see the exclusions down there also. We have 3 or 4 of them. You have a coronavirus infection on specified site, B34 is excluded. It has nothing to do with it. Confirmed laboratory testing, U07 is excluded. It has nothing to do with it. You will not assign it. Special screening examination, whether the patient goes through any special screening, is excluded. You don't have anything to do with it. Or suspected but ruled out by negative laboratory test. You know, that this is a condition, ill-defined laboratory findings. Ill-defined conditions in which you have tested, but it has not proven to be positive. So all of these are excluded. I believe I'm communicating. Moderator, are you on?
Yes, sir. Yes, sir.
All right. Thank you.
Yes, sir.
Now let's look at the explanation. I think I've been able to explain, but let's just run through what we have on the screen, looking at this explanation so that it will actually buttress some of the points we have made. All right. Code U07.1 is for emergency use and must only be assigned for laboratory confirmed cases. COVID-19 positive test result. The other explanation there from the 2 cases we have looked at up there is that codes for conditions classified outside of chapter 18. What is chapter 18? Well, it's talking about symptoms, signs, abnormal clinical findings, and laboratory findings, not elsewhere classified, that are documented as being due to COVID-19 must be assigned after U07.1. So, which means we may have a situation whereby a patient tested positive and there are comorbidities of other conditions or some other signs and symptoms that are accompanying the condition after the patient has tested positive. So after assigning U07.1, other codes, especially those that are classifiable to chapter 18 and B97, any other codes can then follow. Any other code can follow. So this will indicate those conditions that are due to, that is, they are manifestations. You know, we always talk about etiological and morphological stuff in our different consideration. So, which means when you talk about the etiology is COVID-19, and when you talk about other part of it, which is the secondary, conditions or symptomatic conditions that we see as a result of COVID-19. So all those ones will now be seen as secondary, but the primary condition is COVID-19. So further explanation, symptoms codes from chapter 18 must be assigned in addition to a confirmed diagnosis of COVID-19. When there are symptoms, a patient is symptomatic And these symptoms also are clinically identified, or even, you know, the patient is already showing symptoms and these things are already there. We all know, at least we've read, there are so many literature, so many advisories we have read about COVID-19. We know so many of these symptoms that come with COVID-19. I don't need to talk about them. So all of these things must be identified with their specific codes in chapter 18 also stated. So we must bear that in mind. The next point there is U07.1 can be used alone in cases of laboratory confirmed COVID-19, where patients are asymptomatic. So where there are no symptoms at all. The other explanation up there says where there are symptoms. But where there are no symptoms, nothing stops you from just saying, where there are no symptoms identified by the clinicians, you can use your U07.1 as a standalone code, provided there is a testing that proves the patient to be positive. And also code B34.2, coronavirus infection on specified site, and B97.2 must not be used with U07.1, as U07.1 classifies the COVID-19 disease resulting from SARS-CoV-2 infection. So that is why we see B34 and B97 as exclusions. They are excluded in our previous slides. They are excluded. So if you put them again, it means you are just trying to amplify the patient condition, whereas the U07.1 is sufficient to identify a tested positive case. Now, let's quickly look at this. Coding COVID-19 in pregnancy. I believe many of us on the field, we must have come across situations where a pregnant person tested positive, or somebody who came for child delivery, you know, during that period also tested positive. So let's look at the obstetric care for confirmed or suspected case of COVID-19, either confirmed or suspected. What are we to do as a coder? Assign the following codes when COVID-19 is complicating the pregnancy. The reason that brought the patient to the hospital, what was the primary reason? That is pregnancy or childbirth. Okay, the patient has come for, but during the process, it discovered that the patient also, either you confirm, it's been confirmed, or it's been suspected. So U07.1 is used for emergency use. You know, it's a case of emergency, as it were. So emergency use of U07.1 or U07.2 emergency use also. So depending, you know, when it is suspected, it means a laboratory testing was ordered. It has been returned and the patient tested positive, while that same patient came to the hospital for a primary reason of pregnancy or childbirth, delivery or labor. Okay, so if the patient tested positive, U07 will be used for that patient. And also, if the laboratory report comes back negative, U07.2 will also reflect, just to show that this patient was ordered to conduct a COVID-19 testing. All right, because it's suspect. The fact that something is suspected and it has not manifested today does not mean it may not manifest again. I don't want to sound too clinical about it. Now, 098.5, talking about other viral diseases complicating pregnancy, childbirth, and the puerperium. So this is another condition that you may actually, another code rather, that you may put just to make sure that it is further broken down so that it will be explanatory, and all the conditions surrounding that period of pregnancy and childbirth will be captured. So codes to identify manifestation of symptoms where applicable must be put, must be used. We are going to see some of these things in some of the examples that we look at as we round up. Manifestations of COVID-19. Of course, pneumonia is a manifestation of COVID-19, must be followed by, that is when you are coding a manifestation. Underlying cause is different. Underlying cause is COVID-19, but the manifestation of it is pneumonia. Of course, you are going to follow that code. That is U07.1. You follow it with U07.1 will be followed with B97.2. So coronavirus as the cause of disease classified to other chapters. However, B34.2, coronavirus infection on specified site, or B97.2 must not be assigned in addition to 098.5. I know the moderator, Mr. Mercy, you are going to, we should find a way to mail some of these things to our participants so that at least the notes will be with them. And if anything changes in the near future, we can equally address it together. So I think my point is taken. Let's go to the next slide. Confirmed case of COVID-19 during labor and delivery. So not just that the patient is pregnant, but during labor, while the patient is in labor. So when obstetric condition in patient with COVID-19, that is the main condition. Obstetric condition in patient with COVID-19 is the main condition. That is, delivery or labor is the main condition. And the patient has tested positive. Primary diagnosis must be applied. So there is a sequencing order that we are going to see in the example that I will show us down there in some subsequent slides. So there is a sequencing order. So how are we going to sequence it? Codes to identify any manifestation or symptoms of COVID-19 where applicable must be assigned following. So which means in terms of sequencing, in terms of order, COVID-19 code will still come first. So let's look at this example. Let's look at this example. Patient admitted for induction of labor at 38 weeks for IUGR, intrauterine growth retardation. Patient developed pyrexia in labor and subsequently tested positive for COVID-19, but did not require any treatment for COVID-19. Baby girl born. So how are you going to go about it? Don't forget, this is an example of the last slide that we just looked at, in which labor or delivery is the main condition, is the main reason the patient came to the hospital. All right. Maybe the patient has earlier tested positive, but during that episode of care, what brought the patient is not COVID-19. In fact, the patient may even be in the isolation center while delivery is taking place. So when that episode is over and you want to code the condition, don't forget that COVID-19 is already present. So COVID-19 will not be the first code to come up. You can see the order on the screen. So you will have 036.5, which is maternal care for poor fetal growth. Don't forget the condition is IUGR, intrauterine growth retardation. You have Z37.0, single live birth, a baby girl was born, and U07.1, emergency use of COVID-19, U07, that is for emergency because that must indicate that, okay, this patient who has tested positive or possibly receiving care just delivered. The main condition there is IUGR, and you see the child was born and COVID-19, while COVID-19 was also present. That is, the patient has tested positive. So you have 075.2, pyrexia. If you reach the notes up there, the patient also had pyrexia during labor. Okay, so that code takes care of it. And you have B97.2, coronavirus as the cause of disease classified to other chapter. So which means that pyrexia now is as a result. What is pyrexia? Of course, it's fever. Pyrexia is fever. And so that fever that the patient has, of course, is as a result of the coronavirus. Okay, so that is the sequencing that we are talking about. Let's look at another example before we round up, because our time is up, is fast spent. Look at example 2. Spontaneous vertex delivery of baby boy at 38 weeks. Patient is asthmatic, takes Ventolin as required, tested positive for COVID-19, but asymptomatic. What should be the order? Don't forget, these examples are for the obstetric condition, and in a situation whereby the obstetric condition is actually the main condition that brought the patient to the hospital, or that informed that particular intervention at that period in time. So OAT.0, that is spontaneous vertex delivery, which of course is the major thing, vertex delivery. All right, you have Z37.0, single live birth. All right, and you have COVID-19, which is U07.1, of course, and you have asthma. But the main thing that we want to bring out here is that the patient has tested positive. Even though the patient is asymptomatic, it is not all patients that got admitted for COVID-19 that show symptoms. Some will not even show symptoms till they will be treated and they will test negative and be discharged. So these are some of the cases that I think we should just hold on to. And without taking much of our time, because I'm trying to be conscious of the time, we have less than 12 minutes to go. So I'll come to the end of this presentation. There may be a few more things that should have been said, but I'm just being conscious. I have to reduce the slides so that we don't overshoot our timing. Thank you very much.
Yes.
Thank you for listening.
Thank you very much, sir. Wow, it's I'm still trying to download and decode all what that has been said. A colleague of mine has been reaching me like saying, "Is that correct? Is this correct?" I think we still have to bring you back. Then we need to decide on what's the principal diagnosis, what's the intermediate, and all of that diagnosis that we need to capture upon admission of a patient. I think we also need to talk about that. It's not just going to end here today. Thank you very much, sir. So we'll take up some of the questions. And before that, I just want to remind us, please make sure you register your details. I'd like to use the opportunity to recognize the presence of Mr. Paul Oyebanji, the HOD of University of Maiduguri Teaching Hospital. Thank you for joining us, sir. I also recognize the presence of the Director, Health Information Management of the Primary Healthcare Board, Lagos. Thank you so much for joining us. Other dignitaries that we have. Please make sure you register, drop your details in the sheet that we have. And if you can't access the sheet, please make use of the WhatsApp link. So, sir, we have a question here. By Mr. Oyejo, please mute your mic and stop the video. Thank you. Okay, so we have a question here. The question is, having identified these problems, what methods are schools developing to solve the problems right from school, rather than saying coding is a profession? How about saying clinical coding is a specialty? You will agree with me that medical students also took courses in O&G, but that doesn't make them a specialist in that field. And we can't say O&G stands alone as a profession, I think, if I'm correct. So that's the question, sir. Please, we need you to react to that. And a question from Mr. Ruben. He said, how can we convince the management that the system, health information management profession, and the cadre of personnel that should handle coding and other HIM practices, when they assume in all departments, are the same and are referred as technicians, if I got that correct, sir. So I think those are the questions we have in the chat section. So we need you to react to that, sir. Thank you. Please drop your questions. We answer them now.
Thank you very much, Mr. Moderator. And addressing the problems from school is a good thing if the students who are presently in training can develop the right mindset and they understand what is expected right from the school. And but don't let us forget the fact that the school teaches the theory. Let me quickly say this. There was a student of mine and a former student who passed out over 10 years ago. And the person started working in a teaching hospital in Lagos. And another student, about a few years later, went to that same teaching hospital to collect data for a project work. And the older students, I mean the older one who was already working there, was telling the new one, the student who was doing project work, that, well, some of the things they taught us in school, you come to the field, you don't meet them, you don't see them. So when that student came back and told me that this is what she was told, then my question is, whose blame is that? Who is to blame? Because you have gone to school, you have been taught. Yes, we agree, the theory has been taught. Then when you get to the field, you put it into practice. I think the major problem we are having is that many of us pass through the school and we fail to put the theory into practice. That is why we are still where we are. So the theory is being taught. My brother, I will not deceive you. The theory is being taught as it should be. I want to give kudos to those who are working as lecturers. It's not easy. Many of them they read beyond even things they study, they spend money, buy journals to update themselves. They teach the student, but the student gets to the field. At least I know I have produced hundreds of students, if not thousands, in different places where I have taught in the few years that I've been in the profession. But if all of these students get to the field and they decide to make impact, definitely we will not be where we are. So that is actually the problem. It is not so much about the lack of teaching the theory in the school. The problem is about putting the theory into practice when we get to the field. That is actually the bane of this practice. That is where the problems we are facing come from. The emphasis changes the moment we get to the field, and so it becomes business as usual. It becomes business as usual. I used to tell my students that when you go out of school, even though I say it jokingly, but I'm very serious about it. You get out of school and something has changed. Professionally, there are new innovations, and you are telling them, no, this is how Dr. Ayegbayo taught us in school. I said, even if I was dead at that time, my ghost will haunt you. Even though I tell them that, jokingly, but I'm very serious about it. Because things change. We need to move ahead. We need to apply theory. As new developments are coming up, we need to apply. We don't need to, some people, I'm afraid some professionals will be making use of the notebook or textbooks they have read 10 years, 15 years ago, and they're applying that principle into today's HIM practice. It doesn't work that way. So I think let me leave that as that. How do we, that is addressing clinical coder as, clothing as a profession. Why not a specialty? Yes. Let me quickly say this. I was reading an article where nurses, I believe you are listening to me. I want everybody to listen to this, where nurses are giving credits to Florence Nightingale. We all know who Florence Nightingale is. Florence Nightingale is of course, the pioneer of modern nursing practice. And so they are giving her credit for being the pioneer of clinical coding. I believe some of us will want to show some surprise. And they were able to pull some facts. I will look for the article and I will send it to some of us who are interested. Yes, she played some role, but what some of us were used to, we are used to names like William Farr, William Collin, Jacques Batillon, Francois Boussia de la Croix. You know, those names, they ring a bell. But Florence Nightingale also contributed in the development of clinical coding. When we are talking about uniformity of data collection for healthcare services, she contributed about 200 years ago. And so, when we are talking about clinical coding being a profession, even people in other professions in the healthcare industry, they also are laying claims to it. And that is why if we in this part of, when you go to the US, you have somebody who has a degree in nursing and is practicing clinical coding. So, which means clinical coding is a beautiful bride, which many suitors are trying to court. And so if we just leave it as it is, I'm afraid what will happen may not be what we are talking about today. So if we are looking at is our specialty, other people will come, they will double cross, and then they begin to acquire certification in it, and then you cannot stop them. So that is just a note of warning, so that let us establish, let's put ourselves into it. There is this saying in Yoruba, apology to those who don't speak, only enita balaba ni baba. That is, if you are in a particular place first, you arrive in that place first, definitely regards will be given to you for being the pioneer. So all we are saying here is that we should all put efforts together and be pioneers in this. Let me say it, in this new profession of clinical coding. Let all be pioneers. And that is what can help us. Mr. Ruben asked, how do we convince the management that coders are to be distinguished in this situation whereby, well, nobody will blow your trumpet for you, sir, except you blow it yourself. Doctors will come around and they call you card issuer, they call you medical record technician. They can call you any name they choose, but what are we calling ourselves? Yes, you can write memo, you can do this, you can back up with releases from the Health Record Officers Board that they have said we should be addressed as HRM professionals. Yes, we have coding, clinical coders association. You can do all that, but how do we actually address ourselves? Kudos to many of our professionals, you know, who stand their ground, who are able to, you know, prove because they know their onions, and they're able to, in the past and even in the present, many people, many beautiful professionals, many good professionals that we are not all, you know, bad. Many of us, we are doing well in our respective, but we know that one tree cannot make a forest. And that is why how you blow your trumpet really matters. If you refuse to blow it, let's blow it. Let's conduct conferences, seminars. Let's invite them. Let's do us to reckon with. Let's write papers. Let's develop formats that they have never seen before. Let's do, you know, researches. And when we do all of these things, it will be difficult for a group of people to just come and, you know, just wave you off as if you don't matter. So I just want to stop there I don't want to overflog it. It's 4 o'clock. I don't know if we have more time. So, Mr. Moderator, over to you.
Yes, sir. Our time is fast spent already. Thank you very much. I don't know if you can just have the room to take this last question. What is the relevance of the clinical coder when coding can simply be done electronically? What's the notice that wasn't answered? Hello, sir?
Can you say that again, please?
Yes, sir. Okay. The question is, clinical coder when coding can simply be done electronically.
I didn't hear that. I didn't get it.
Okay, sir. I will take it again. What is the relevance of a clinical coder when coding can be done electronically? That's the question from.
Okay. Yeah. I think in the body of the presentation we did earlier, this first session, that the fears that many of us have is that when we have new technologies being deployed in clinical coding and HRM practices, that is going to, we have that fear that is going to displace us. But whereas technology is not going to displace the coder. One thing is that the technology, the software, the artificial intelligence, they are designed to make the work come out better, to improve the quality of the work, to equally make us to come up with more accurate data that can be used for effective decision making. So it's not going, let's look at it. We have software, a good example. We have software being used in banks. We have ATM machines, or don't let me say machines now, ATM that have been, installed in different places in our banks. Does it mean, yes, in as much as you can have ATMs dispensing, don't they still have bankers, people who are working behind the counter? They still have. So technology on its own cannot, even when we deploy telehealth and we have remote stations where computers are being used to take down patient complaints and the rest, somebody, human brain must still coordinate. And so, regardless of the fact that technologies are being deployed in coding, it doesn't change the fact that coders will lose their relevance. The only thing that can make the coders to lose their relevance is if they fail to develop themselves to meet up with the challenges of the times that they live in. Thank you.
Thank you very much. That's beautiful and short. Just in addition, I would like to just chip this in. ICD-10 now is expandable. It can expand to up to like 7 digits. It's kind of sad. Most of our system here in Nigeria, most don't even know it can expand. So I think it's a way we as clinical coders need to think and pull ourselves together and make sure clinical coding grows as a specialty. Thank you all very much for joining this webinar today. We sincerely apologize. We are out of time already. So we will still have another session. I'm going to come back to the table, and then we also have another discussion. A big thank you to our speaker, Dr. Ayegbayo Falashayo. He has PhD in health informatics. I think that's a plus to us in Nigeria. Thank you very much. He has vast knowledge in coding. He has been coding for 2 decades now. So he's a lecturer. He teaches students on clinical coding. He has a textbook on clinical coding. So he has vast knowledge on clinical coding. Thank you very much for joining us today. All our invited guests, those that participated, thank you for coming. I could see a lady driving, and then she still made out time to join this webinar. Thank you all for joining. So please make sure you enter your details so that we will send invites to you for the subsequent webinars, and then we'll be able to get hold of you anytime you want to have another session like this. Please, if you can't access the Google Sheet, we also have the WhatsApp link there. please go there and enter your details. You will definitely get back. Hear from us, and we will definitely get back to you. A big thank you to all the partners that made this webinar a success. The Renaissance team, Mesho ICD, Healthcare Coding Institute in Lagos. Thank you very much. Really appreciate your kindness. This is not the end. We are still going to see you in the next one. Have a wonderful evening, everyone. Thank you, and bye-bye.